We're going to move, and again, we're looking at the whole long-term care system, and a really important aspect that we often tend to forget is the role, is the importance of rehabilitation. And in the context of COVID, we're aware of the impact that that's both of the reduction in access to rehabilitation, but also the rehabilitation needs that may have been generated as a result of both the virus itself and also the restrictions. So we're really delighted to have Miriam Haaksma here, who's going to be presenting on a European-wide study on the recovery of post-COVID-19 and patients in geriatric rehabilitation, daily functioning, and quality of life. We'll actually be watching a video of the presentation, and then Miriam is here to take on some questions. And I think we can get started with the video. And now that's the moment of crossing fingers that it all works. Looks promising. And we don't hear it yet, Daisy. Are you? Okay, the sound coming through?
I did say share sound, but it seems to not be working. So I'm just going to keep myself unmuted, and hopefully that will work.
Again, I can try sharing it if you want.
Yeah, you can. Do you want to try?
Yeah. Sure. Here it goes. I think you can see it now.
Yeah.
Hi, everyone, and welcome to this presentation on the recovery of post-COVID-19 patients in geriatric rehabilitation. And today I will focus with you on daily functioning and quality of life in this patient group. And during this presentation, I will present you the preliminary results of our EU COGRE study. EU COGRE stands for European Cooperation in Geriatric Rehabilitation Research. And I would like to start by showing you a short movie featuring healthcare professionals who are part of our cooperation.
Ik denk dat het ons als multidisciplinair team toch nog meer versterkt heeft.
And COVID-19 makes classical work difficult, since you cannot have the usual spaces because the patient must be isolated. And also the absence of the family's members, it's difficult in the process of rehabilitation.
Eigenlijk een hele nieuwe doelgroep hebben leren kennen. Een doelgroep die heel gevarieerd is, de ene patiënt heeft longproblemen, de andere is fysiek heel belast. Sommige mensen hebben orgaanproblemen. Het is niet zeg maar te vangen in één ding. In het begin dachten we van nou, dit zijn allemaal longpatiënten, maar dat blijkt dan niet zo te zijn.
Met name flexibel we het met z'n allen hebben opgepakt, dus onze instelling daarin.
We are proud of, with no doubt, of the resilience of the professionals, the hard work of the members of the team.
We hebben wel een enorme expertise opgebouwd en daar ben ik echt wel trots op.
All right, that was a short movie to start with, and I would also like to start by acknowledging all of my colleagues and collaborators without whom this study would not have been possible. And now a brief introduction. Older people are at higher risk of COVID-19, as you know, and therefore they are also at risk of subsequent ICU admission. This can lead to multi-organ failure, pulmonary dysfunction, sarcopenia, pressure ulcers, and post-traumatic stress syndrome. And all these things combined can cause functional and cognitive decline. From previous research, we know that 30 to 50% of hospitalized patients require post-acute care. And Therefore, some of them may be discharged to geriatric rehabilitation. Geriatric rehabilitation is a multidisciplinary approach and is one of the post-acute care options that is specifically aimed at multimorbid and vulnerable older patients. And although the need of geriatric rehabilitation has grown higher than ever during the pandemic, the availability of geriatric rehabilitation is historically low, as many healthcare professionals were either ill or transferred to acute hospitals due to the scarcity of personnel. And this is what we call the COVID rehabilitation paradox. Now every country copes with this rehabilitation challenge in their own way. And this is actually what inspired our EU cohort study. So this study has two main aims. The first one is to gain insight into the recovery of older COVID-19 patients during and after their stay at the rehabilitation department. And the second one is to gain insight into the content of post-COVID-19 rehabilitation in various European countries. Our study is a multi-center observational cohort study, and we included patients who were admitted to geriatric rehabilitation after SARS-CoV-2 infection in 66 health centers across 10 European countries. We include patients who were admitted to rehabilitation with COVID-19 as a main diagnosis. And we measured information about their health status at a pre-morbid time point, which was 2 weeks prior to the COVID infection. Then at the moment of admission to geriatric rehabilitation, at the moment of discharge from rehabilitation, and 6 weeks and 6 months post-discharge. By the way, can you see the pointer now? Yeah, okay. So what about our outcome measures? For our first question, where our primary outcome is ADL functioning, and our secondary outcome measure is quality of life. Now, ADL functioning, which I refer to as daily functioning in the rest of the presentation, it includes basic functions and tasks you perform throughout the day, like toileting, eating, dressing, and transferring. For our second research question, we focused on the treatments and healthcare professionals who were involved in the treatment of the patients to see how these factors differ across the countries. This is an update from October 20th, at which time point we had included 712 patients from 10 different countries in our database. And here you can see in orange all the countries that are participating. Now, it should be noted that data collection is still going on, and the follow-up continues until the spring of 2022. So everything I will show you today is quite preliminary. But as you can already see here in this map, it is notable that the Netherlands stands out with number of inclusions. We have the far majority of the patients is from the Netherlands, being 298 as of October 20th. And I think that this high inclusion rate is notable, and therefore I would like to briefly touch upon the research infrastructure that we have in the Netherlands, which we are really proud of. And as some of you already know, we work in a network called UNCZH, which is also called the Living Lab, in Dutch UNCZH. And together with health professionals and in elderly care organizations, we work to collaborate on research and collect research data. And we do this in the following way. We have a collaboration of Leiden University Medical Center with 12 elderly care organizations in our province. And in those elderly care organizations, we have scientific committees and linking pins who support us with the execution of our research. But they don't only support the execution of research ideas, but they also help us in generating the research ideas. And 6 provinces in the Netherlands have this kind of living lab. And these strong connections between and within these living labs enabled us to recruit these many patients for our study. Now here you see a picture of one of our national coordinator meetings, because you may wonder, how did you organize the study in all the other countries? Because of course, not all countries have living labs like the ones I just showed you. So in order to make the study fitting for each of the participating countries, we appointed a national coordinator in each of the countries. And here you see the picture of one of these meetings with the national coordinators. And at each of the participating rehabilitation sites within the countries, we also appointed local coordinators who enter the anonymous research data into our database. So we have the national coordinators at the top and then local coordinators who are working to enter the data. Here's an overview of our collected data so far, and this is the availability of the Bartel index. And as you can see, most of our data we have collected was at the moment of admission, and most patients have also been discharged already, so that number is quite high as well. Now, obviously, with follow-up, the availability of the Bartel index decreases because not all patients have been followed up yet. And of course, there's also some loss to follow-up over time. But we expect those numbers to increase in the future. Now we come to the very interesting part. The results and characteristics of the included post-COVID-19 patients. Here you see that the mean age of the patients in our sample is about 75 years old, and approximately 50% of them are male. Most frequent comorbidities are obesity, pulmonary disease, heart failure, and diabetes, which are known to be prevalent comorbidities in this patient group. And about 90% of the patients were admitted to the hospital before they were admitted to geriatric rehabilitation. And 35% of them are admitted to the ICU as well. The median length of stay at the ICU is 24 days and median rehabilitation length about 25 days. So this is very briefly what the patient population looks like. Here you see our rehabilitation length that I just said median is about 25 days. Important to note is that this length really differs by country, as you can see here. So longer durations, for example, are observed in Malta and Spain as compared to the UK and Germany. And we suspect that these differences are the result of differences in inclusion criteria. So not inclusion criteria of the study, but selection criteria that occur along the way of the triage. So when people are selected to undergo rehabilitation or not. So these differences likely depend on the type of patients who are eligible for geriatric rehabilitation. And that is not the same. Actually, one of the things we found in this study is that the definition of geriatric rehabilitation is not even the same. So in different countries, people can mean different things when they talk about geriatric rehabilitation. And that was one of the hurdles that we encountered when setting up this study. So we had to be really clear about what type of patients are we talking about. Now, to show you something about the frailty of the patients, here you see that at the moment of admission to rehabilitation, about 2/3 of our patients were moderately to severely frail. About 30% was vulnerable to mildly frail, and 10% was managing very well. These are the results of our primary outcome measures of the first research question, and that is something that I would like to focus on right now. Because you see a very interesting pattern. At the pre-morbid time point, which was 2 weeks prior to the COVID diagnosis, you see that the Barthel index is about 18. And then, as expected, at the time of admission, once the patients have had COVID, the Barthel index has dropped. So this is the scale for their daily functioning, right? So it has dropped to about 11. But by the time they are discharged from rehabilitation, you see they have recovered to a score of 16. And this recovery remains stable after 6 weeks and 6 months. So what we see is actually that patients seem to recover quite well when you look at daily functioning. And although we don't have pre-morbid measurements for quality of life, we do see similar increase after geriatric rehabilitation in this outcome measure. I'd like to show you the same thing, but then in graphs. Here you see the graph of daily functioning. And as I just told you, you can clearly see that in each of the countries, we have this pattern where the daily functioning drops up to time point 0, which is the moment of admission to geriatric rehabilitation. And then after admission, the daily functioning increases again. And you see that here for the first 6 countries, but also when we look at the other 4 countries that didn't fit the slide, you see the same. So this pattern is consistent, although we do see differences. The drop is not as large in each of the countries. For example, here in Russia, patients seem to drop only very little before going up again. And again, we think this difference is the result of differences in patient selection for geriatric rehabilitation. We know, for example, that in Russia, most people receive rehabilitation in the home setting. And by definition, that means that this is a really different patient group from patients who receive geriatric rehabilitation in the Netherlands, who are all admitted to departments in a nursing home. So you can imagine these are completely different patient groups. But nevertheless, we see the same kind of pattern, which is reassuring. Now, when we go to quality of life, as I said, we don't have a pre-morbid measurement. So here the graph starts at 0, which is the moment of admission, and we see the increase. It's not as clear in each of the countries, but we do see, in general, an increase. Of course, not for all the individuals, but on average, we do see an increase. Now, another very important outcome measure when we look at geriatric rehabilitation is the discharge destination. Most of the people, for most of the people, this outcome shows us good news, because you see that about 3/4 of the patients are discharged home. So about 90% of them came from home before they were admitted, so their pre-morbid residence was also home. And then in most of the cases, they were also able to return home. For about 15%, this was not possible. They had to move into an assisted living facility or nursing home. 4% was readmitted to the hospital, and about 1% died during the rehabilitation. So our preliminary conclusions from these results are that many patients are almost back at their pre-morbid level at the time of discharge, and quality of life strongly increases during geriatric rehabilitation. So this is really good news. And in addition, about 3/4 of the patients was able to return home. So altogether, substantial recovery is observed during and after geriatric rehabilitation. Now for our future steps, follow-up data collection will continue until the spring of 2022. And we are looking forward to examining many other things with this data. For example, we want to examine the influence of factors that are associated with recovery. And also we want to quantify cross-country differences in recovery. In addition, we want to examine differences in treatment across countries, because we expect that because the definition of geriatric rehabilitation is different, also the content of the rehabilitation will be different. And we believe we can learn from each other as countries. And that's, of course, the entire point of conducting this study, to learn from each other and eventually improve geriatric rehabilitation. This was a brief overview of our study so far, and feel free to contact us or ask any questions.
Thank you very much, Miriam. And we have 5 minutes or 6 for questions even. I am going to go first as using my prerogative as a chair. And I did notice that there were more people being discharged to a care home than having come originally from a care home. And I was wondering whether you could say whether there were differences between countries, or whether, and if this is something that you might be analyzing further as well.
That's an interesting question. We didn't stratify the discharge destination by country yet, but I do believe that would be very interesting, as with the other outcomes like the Martel Index and the quality of life. We will look into that later, I'm sure of it. Thank you. Thank you.
And are there any questions from some of the other participants? I do have one more, so I think I'll just use the opportunity. Yes. And has the issue of long COVID come up in your sample? And do you have people who, I mean, I don't know where this, how this is identified in different countries as well, because I know it's a little bit complex. But I just wondered whether this is something that may emerge. And I mean, I will explain why I'm asking this. And so thinking a bit from the point of view of future need for care, it is important to also consider whether people who have had COVID, you know, this might result in a change in the need for care, or the numbers of people who may need care from others due to not recovering abilities, or perhaps the disabling effects of long COVID.
Yes. Well, we didn't specifically ask whether someone suffered from long COVID at follow-up, but as mentioned, we have follow-up data at 6 weeks, at 6 months post discharge from rehabilitation. So we suspect that that people who do suffer from long COVID will show lower scores on daily functioning and quality of life at follow-up, and may not recover to their pre-morbid level even after 6 months. So if you would define long COVID as not being able to recover within 6 months to your pre-morbid level, then we would be able to look into that. Of course, it would depend on your exact definition of long COVID.
Thank you very much. And is there any other quick question for Miriam? And what I would say then, we have a hand from Crystal Nicoli.
Hi, Adelina.
Hi.
I have my question, I guess, for Miriam, and in this presentation about rehabilitation is, in our situation here in Ontario, the funding by our government is that rehabilitation can't be provided in the hospital if the resident belongs to a long-term care home. So I'll give you the example. If my mother, yes, everybody's nodding their heads in agreement. So if my friend whose mother had a head injury, you know, and now has to be rehabilitated, it is not done at the hospital because the dollars are dedicated to the long-term care home. And then, of course, at the long-term care home, when you bring them back, which she did last night, for example, and we all know this issue, it's gone on many times, there is no rehabilitation services. We have on-site PT that can be provided for 10 residents 3 times a week. There's no neurologist, there's no geriatrician, there is no rehabilitation services to actually in the homes at this point. So, or very limited. I won't say no. I'll say like very limited. And we've talked about this before. So I'm kind of wondering is how that sort of fits with your findings. And if you could comment on that.
Yes, I can comment from the Dutch perspective, the way things are in the Netherlands. What we have is a definition of geriatric rehabilitation that aims to enhance independence and help people return back to the home situation. So by that definition, it also excludes people who are already not living independently at home anymore. And we see the same, that when people are coming from the nursing home, they don't get the indication for geriatric rehabilitation anymore, because by default, they will return to the nursing home. However, the geriatric rehabilitation departments are in the nursing homes in the Netherlands. So because these are coupled, I think the availability of rehabilitation is a bit larger for people living in nursing homes, although it will obviously depend which nursing homes you live in.
Thank you very much, Miriam.
Sure.
Thank you very much, Miriam, and we'd love to follow your study, and please keep us updated. I know we have it in the LTC COVID Research Project's website, and I will also be in touch about sharing the video and also maybe the slides. So thank you very much. Please keep us updated when you have more findings.